Dear audience, I'm very pleased to find myself today here in front of you to present the progress attained on my PhD during the first 3 months of it. The title of my thesis is called New Insights Upon Adverse Events of Statin Treatment, and my name is Cozma Tudor-Cristian. I am part of the bilateral program of PhD, both here in Budapest and back home in Iași. Peter Ferdinand, Renata Papa, and Ionela Lacremera Șerban are my distinguished supervisors. Mary Ann is my scientific methodology expert, and my trusty SMS is Amir Makoli. I came here to Budapest with a certain vision, that I want to provide prolonged, healthy, and independent lives for the elderly. My team and I will accomplish that by conducting research towards providing evidence regarding the role of common medication on the musculoskeletal system of the elderly population. These are my specific goals, that is 2 projects which I started this autumn, and both of them will be performed using the systematic review and meta-analysis method. Here we will talk about the first project, titled Investigating the Effect of Statins on Development of Sarcopenia, and as you can see, this is very close to my vision. Not only is sarcopenia a very widespread syndrome across the elderly population, but its prevalence varies from approximately 10% to 27%, depending on the analyzed population. Also, sarcopenia brings tremendous cardiovascular and general health burden both to the patient and to the practitioner. Statins have varied mechanisms through which they influence the overall muscle mass and muscle function. Considering that almost 20% of the population today is and will be recommended for treatment with statins by 2018 cholesterol guidelines, it is understandable why the negative pleiotropic effects of statins will surface, will be experienced by the patients affected, to say the least, undergoing this treatment with statins, and also will be experienced by the practitioner who will have to deal with these complications. Therefore, the aim of my team is to demonstrate whether there is a significant association between continuous statin use and development of sarcopenia. We employed the PICO framework, where population of interest is represented by adult patients treated with statins, compared to as closely matched as possible a population not treated with statins. Outcomes of interest revolve around sarcopenia as a syndrome, which is based upon 3 main pillars. That is, lower muscle mass, reduced muscle quality, and impaired physical performance. Our hypothesis is that treatment with statins is safe regarding the risk of sarcopenia in adult patients. The clinical implication of our study will be reflected through a more thorough, a better understanding of the practitioners towards the role bear by statins upon quality of life in elderly patients. Here's our final search key based upon 2 domains, that is the intervention and the outcomes. We included in the intervention every single statin still in use, and the outcomes, while they are not restricted only to sarcopenia, they have been extended also to frailty syndrome in order to hit every single article possible and useful. Here you can see 3 of my main articles that are going to be analyzed in the final study. They have been published in very prestigious journals. In this case, they all analyze hand grip strength as an outcome, and the populations are relatively overlapping. That is, community-dwelling elderly patients, polymedicated, and who are not currently diagnosed with any disease that could lead to sarcopenia before statin treatment. This is our progress for the first project. We find ourselves in the title abstract selection phase. There is a tremendous amount of work since our number of hits after duplication removal is almost 1,600. We plan to finish this phase up until Christmas. And now talking about the second project, assessment of the efficacy and safety of new anti-diabetic drugs on improvement of inflammatory profile. Again, this will be performed using the same systematic review and meta-analysis procedure. In 2021, almost 530 million people were affected by diabetes, and this number is expected to rise to up to 1.3 billion people by 2050. The bulk number of this will be represented by type 2 diabetes mellitus, and most of them will find in the 65 to 74 years range. With getting older, the cardiovascular burden is also increasing. And this cardiovascular burden has a main pillar which is represented by fibrosis. Fibrosis, which again is a consequence of inflammation. So if practitioners will employ as many or as useful medications as possible towards reducing the inflammation process, the outcome for patients will be better. As is the case for GLP-1 agonists, if you imagine that the final step, that the tip of the funnel where all actions of GLPs concentrate into one point, the main action of GLP-1 agonists or analogs is represented by a reduction of the activation of NF-κB, the prototypical pro-inflammatory factor. In a similar case, SGLT2s also act at very strange sites inside the cell, which ultimately return again to reduction of activity of NF-κB. Therefore, employment of this kind of medication and finding out which one is the most efficient will allow practitioners to prescribe the correct medication and in the correct dose to the right patient. We employ again the PICO framework, where the population of interest is represented by adult patients, intervention by new antidiabetic drugs, that is GLP-1s and SGLT2s, compared to placebo, while outcomes of interest are mainly represented by inflammation markers, and they found ventricular function and major adverse cardiovascular events. The articles that will be included under the GLP-1 arm are presented as follows. Main outcomes, C-reactive protein. Our next task is to find articles that compare either drug to drug from different classes and SGLT2 to placebo in order to turn this ultimately into a network meta. As a summary, these are my two projects, and I have established a final submission date because this is how I work under extreme stress. And I would like to end my presentation with a quote. Success is not final, failure is not fatal. It is the courage to continue that counts. Thank you so much, and I'm waiting for the questions.
Thank you so much. Already 2 questions.
Thank you for your presentation, very interesting topics. Regarding your first project, there is massive data on statins that in these populations you showed they are very beneficial. So my question is that if your result is positive, let's say statins can cause sarcopenia, what's the next step in the future in the management of these patients? Because as we know now, they really need statins. Or you want to add other kind of drugs like ezetimibe or something like that? Or how do you think you can improve the management with these results of patients?
Yes, I understand the question. First of all, from what I've read during the selection phase, safety of statins is not entirely uniform. So we have already found certain articles that mention that people undergoing statin treatment will develop some kind of sarcopenia, but not every single parameter that defines sarcopenia, only certain physical measures. Second of all, if our study will prove that sarcopenia is determined to some form by statin treatment, I think the main action will be for the practitioners to reduce the doses or switch to other classes of medications. From what I've read by now, ezetimibe is very highly employed against statins or compared to statins or added to statins, as are PCSK9 inhibitors. So I think these two classes will at least compete with statins if our results will prove positive.
Thank you. And one more question: that are you planning to differentiate different doses? For example, 10 milligrams rosuvastatin and 40s, it's a big difference in practice.
Yes.
So what is your plan regarding this question?
That is an amazing question. That is a very big limitation we have in our study. That is, most of the articles we have included up until now, the authors do not mention three things. They do not mention dosage in most of them. They do not mention, some of them do not even mention the type of statin they use. They just mention statin as a percentage. Further, they don't mention adherence to treatment. So we don't know if the patient, although he is prescribed the statin treatment, we don't know if he takes the medicine. And lastly, we don't know for how long the patient has taken that statin. Maybe he has taken it for 2 weeks and has come back for a reevaluation, or maybe he has taken it for 1 year. We don't know. So these are some limitations that we will have to address. Yes.
Thank you.
Thank you. Next question, I think Bertrand.
Thank you for your brilliant presentation. I would like to ask how you plan to assess the drug-drug interaction. That, I mean, we know about drug-drug interactions, and most of the patients are on statin, who are on statin are polymedicated. So, what's the plan?
Thank you for the question. Yeah, this is a difficult part of our study. What I mean by this? First of all, statins are a drug class designed to be very specific in action. They are designed to inhibit only HMG-CoA reductase hydroxymethylglutaryl coenzyme reductase. Second of all, most articles that I've encountered so far are mainly case reports or case series. So there's not a very widespread awareness towards drug-to-drug interactions. Moreover, the only articles that I encountered concerning drug-to-drug interactions mainly were about three medicines. So, cyclosporine, gemfibrozil, and the last one I cannot remember right. Colchicine. Colchicine was the last one. Out of these three, from what I read, the interaction with gemfibrozil was the most feared by the practitioners. However, in those cases where drug-to-drug interactions occurred, patients had either a liver failure or a reduction in liver function or a kidney failure or a reduction in kidney function. So there was a component of reduced elimination, not necessarily drug-to-drug interaction in a normal, usual patient that is prescribed statins. I hope I've answered your question.
Yeah,
so
yeah,
again, we will analyze case reports. We will analyze any case series that mention, but we have to take into consideration the profile of the patient that encountered these drug-to-drug interactions.